approval, for example, with the FDA, and then actually being used. That's amazingly quick. And the only thing I can think of that's comparable is COVID in the last few decades. So the first one, I think this actually came out. I think the results of this came out a few weeks or months later on, but this was the first one to be published, I think. So this was a maternal study in which the concept was to vaccinate mothers with this vaccine, with RS vaccine, F protein related, which was antigenic in mothers, in order that they generated an antibody response, primarily in terms of IgG, and because this was last trimester vaccination, provided they had enough time, babies weren't born prematurely, to generate an immune response, the fetus received passive IgG transfer. So that's how it works, in much the same way as tetanus and pertussis have been used, but never in RSV before. And I'm not going to go into the fine details, but I can say that this was a very well run study. Thousands of women enrolled. And what I like about this study was it didn't just use a seroconversion endpoint, but it used an actual disease outcome endpoint. And what they used was medically attended severe RSV associated lower respiratory tract illness. So the women didn't know which group they were randomized to. The control group got a placebo vaccination. So it was completely blinded from that point of view. It wasn't as if mothers, with the knowledge that they'd been vaccinated, presented later. This was totally blind. And they found quite phenomenally good results. So that 6 months efficacy of 70% basically. So 70% reduction in the first half year of life in paediatric resource presenting RSV illness. And for those of you who've been inundated with RSV for more winters than you can remember, that's a pretty good result, impressive. No safety issues, and the FDA, they didn't hang around, to their credit. They endorsed this very quickly, and it's now available not only in the US, but quite widely now. And literally at the same time, this is incredible. I've never come across such. It's possible that there was some overlap between the study groups in terms of exchange of ideas, but this was a slightly different one in that it was testing neonatal infant vaccination before the first winter. So again, another RCT, but the vaccine this time wasn't an active one. It was a monoclonal antibody. So a single a single dose of nocidimet, which is the one that's been used most widely now, although there are others, before the first winter, within the first 6 months. And again, the primary outcome was of medically attended illness in the first 6 months. And this was even better. This had an efficacy of around 75 or even 80%. So very effective, hard to argue with these sorts of data. And subsequently there have been lots of other monoclonal antibody studies. So both in a way, the second one, the infant one, definitely a passive vaccination. The first one really, in terms of what the babies receive, a passive one because they're getting passive transfer of IgG antibodies. Either way, the baby ends up protected. And so the only, I don't want to say stumbling block, the only issues to overcome, as is usually the case with these sorts of things, is cost effectiveness. And the companies clearly sold their case reasonably well. And this is now generally available at a price that keeps everyone happy. So it's been widely instituted in the US. And in the US, I'm not sure if this is done state-wise or by parental preference, but it's both the maternal and the infant one are widely available. In Spain, both are widely available, but I think they've used more nirsevimab at the moment. In the UK recently, after some consultation, we decided that from September, so it's literally in the next month, it'll be the maternal one that's rolled out. In Sweden, the maternal one is available, but I think the negotiations around cost are still ongoing. But I would be surprised if this time next year there wasn't far higher uptake throughout Europe. This isn't going to go away, and it makes good sense. So that's any questions on that? No, that's a very good question. You probably don't need both. Very, very good question. I mean, either way, the bottom line is you get IgG. So I don't think they'll counteract each other, but I don't think there'll be much of an additive effect. Because one's already at 70%, one's at 75%. So I think the choice is one or the other. And that's being decided at individual country level. But the cost in LMICs hasn't really been figured out yet, and its availability. And of course, that's where the burden is. I hope something gets sorted there. I don't know what the WHO are involved in negotiations at this point. Do you know if it's available?
No, but in general, I mean, the thing is that you probably need a lot of volume for passive antibodies to give, right? I mean, the whole, as opposed to the vaccines, which we have the system for all the vaccines, where it's this one-time injection, small volume. I mean, if you need, I don't know how many hundreds of ml of this antibody to be given.
I think it's just a sub-cut injection or a 1 IM injection. It's incredibly little. It's compared to the normal sort of monoclonals. It's so small that it can be incorporated into routine program without any extra.
Even the antibodies?
Yeah, like 0.5 ml. It's tiny.
Yeah, I mean, I think cost or something, but people will probably have to pick one.
Yeah, I agree. I just hope it becomes available. It's just
even in the West, right? I mean, in the West, people would, for example, why is the UK going for passive antibodies when you have that trial?
Very good question. I think what happened is that there was some dialogue with pregnant. They spoke to some pregnant mothers and asked them what their preference would be, and in the end decided going that way. And I'm not everyone agrees that was the right choice, but doing something was the right choice, and time will tell. It might go back in the other direction. So malaria vaccination, people have been trying for decades to get this going. Despite previous attempts, it's for lots of reasons, largely complicated life cycle and complex and varied antigen structure of the different life cycle stages of the parasite. It's been very hard to get an effective malaria vaccination, and some years ago there was the first well-known attempt was a Colombian one, SPF 66, if I remember correctly, which was better than nothing, but not particularly effective, and people, after transient interest, lost interest. And then about 10 years ago, circumsporozoite protein-based vaccination, the RTSS, was tested in multiple sub-Saharan African centres and proved to be pretty good, so 25-30% effective. And people at the time were, okay, that's all right, but it's not the answer alone. And then over the next few years, people started to think, well, maybe that isn't good. That was never going to be the overall answer. There was never going to be a single vaccine that coped with all the different species, components of the life cycle, but provided it's done in combination with the now known to be effective control measures like vector control, permethrin, bed nets, indoor house spray. It's quite a lot more selective fever case management, PCR testing, intermittent prophylaxis is quite new from the WHO for young children and pregnant women. That's new from the last WHO roundup. Maybe this will actually round things off quite nicely. So the WHO rethought things and thought, actually, we haven't got anything better in the pipeline. It is time to launch this. And that's why I'm presenting this, because this has now happened. All very recently, and in 3 initial sites in sub-Saharan Africa. About a year ago, it was finally officially launched. These are all from the original trial, and showing fairly steady, reasonable protective value, but not dramatically. Never enough on its own to be the only intervention. But in combination with the other measures, this might be something. And it was time to offer something. So in 2019, the WHO piloted this in Kenya, Malawi, and Ghana. And it's now finally, and this is why I wanted to show these slides, been formally introduced in malaria endemic vaccination. So the idea is all children, as part of their routine vaccination, get four doses, starting at about 5 months of age. 5th dose, I don't know how many are getting. That's an optional extra at the moment. So that's exciting, that there's some vaccinology in the malaria programs, even though it won't be the final answer. And in reality, it may never be the final answer. That's just the way these things are. Without an echo, it's very hard to say. But in the old days, when there weren't many ultrasounds around, used to use terms like egg on side and boot shaped. Well, this is an egg on side heart, which is what transpositions are supposed to look like. So there's a bit of historical backdrop to this. So since ultrasounds and antenatal ultrasound particularly became more widely available, the standard process for not just cardiology but all sorts of potential congenital problems has been to obviously inform the mother and do something about it. And this has been the practice in cardiology for what are deemed serious cardiac abnormalities for some time now. And this study from Australia looked at whether this was necessarily, or the current process after a diagnosis, transposition positivity, is necessarily the right thing to do. And this was I think, very brave study. We went through lots of iterations because I don't often lose sleep about manuscripts, but this was one which I felt was so counter to general thinking that I needed to be very careful, multiple statistical reviews, and in the end I was comfortable and totally confident in what the authors had to say. So this was a big study from Victoria State looking at 10 years worth of data and testing the hypothesis, essentially, that their their then current program of managing antenatally detected transpositions was necessarily the right way to go. Not a trial, but they looked at mothers where there was an antenatal diagnosis and those in which there wasn't a transposition, and the outcome. And you think that the babies of those women who knew antenatally would fare better. But that's what they were looking at. What happens when you know? Well, you are transferred to fairly close proximity of the tertiary cardiology centre. When you're getting close, the paediatricians know that your lesion might be dependent, so someone draws up prostin. But what might the downsides be? Well, that's what this study sought to look at. And as I say, it's quite provocative. So this was data from about 10 years in Victoria State. I think most of the surgeries there, maybe all of them done in Melbourne, and yeah, very experienced. And of those, 70% of the ladies had a prenatal diagnosis, and 30% of babies with transposition were previously undiagnosed. And what they found, I won't go into the details, you'll have to take my word for it, but this is a rigorous review. And they found, quite simply, that gestational age and birth weight centile were lower, and small for gestational age babies lower in those diagnosed prenatally. Well, you might say that's confounding, but what they found on doing some mediation analysis was that the likely mechanism was that mothers who knew were then delivered earlier. Babies were therefore a week or so more premature. Prematurity corresponds to a degree of lung disease, and they had longer ventilation times, longer time on PICU post-operatively, and so on and so on. There was virtually no mortality, so no difference there. But it's quite interesting because what else happens if you tell a family that the baby has a serious congenital heart problem? What starts to circulate in your blood? Stress hormones of some sort, to use a collective term. And that isn't necessarily good for the baby either. They didn't have any data to show that. They didn't do surviving cortisols or anything like that. But it's interesting, and they showed the outcomes actually better in those women who didn't know that their babies had congenital heart disease in advance. As I say, this went through several iterations, several editorial discussions, several rounds of statistical review, because this is one I didn't want to get wrong. Well, I don't want to get any one wrong, but this one particularly. And we'll see what happens. We can't, of course, like any observational data, you can't extrapolate necessarily beyond the population in which it was conducted. So we think this is valid in southern Australia, no reason to believe it isn't. Whether it's generalizable, I would think so, but I can't prove that. And we'll see if this changes practice. But not everything we do, the bottom line is that not everything we do, not all our practice is necessary, though well intended, isn't necessarily the best way of doing it. And it's to always have that at the back of your mind. And challenge dogma, I suppose, is the bottom line. Now, whether obstetricians start doing things differently, I don't know. I don't think this is going to change management radically, certainly not in terms of antenatal scanning, because that's well established, and there are lots of things you pick up which are worth knowing about in advance. But whether the baby should be induced and delivered earlier is debatable. So I just leave that one at that, and let's see what happens. To show you, so I want to talk about febrile neutropenia. How many of you are involved in oncology or hemonc in some way? Good. So, in many ways, the biggest burden of ongoing treatment for children who've got an oncological diagnosis, who've had their induction, which is very unpleasant. They largely spend most of their time in hospital, and then go on to maintenance of these episodes of febrile neutropenia. And that's relevant for children with pretty much any sort of cancer. chemotherapeutic drugs pretty much all have the downside that they take away cancer cells, but at the same time they reduce your white cell count, particularly neutrophils. And in children with this phenotype, if you like, the risk of sepsis is very much higher. So fever in this group is to be taken very seriously. And traditionally, this has meant different groups use different guidelines, but most are based at around one fever spike of 38.5. If you're on maintenance chemotherapy, means at least a visit to hospital and almost inevitably cultures, and then up to 5 days in, even if you're relatively well, which is the way it is. And chemotherapy, the maintenance phase eventually comes to an end after 2 or 3 years, depending on gender, and it fades into a bad memory. But the question that this group looked at, and this particular study is from the UK, but it's based on data from Australia and Switzerland, which have also examined the same issue about how long do these children really need to stay in when they're relatively well children who are in a low-risk group, who don't have any red flags, essentially. Is there a way we can get them home faster, but safely at the same time? And I'm not going to go into a lot of details, but these groups have looked in very great analytical detail at data sets. They have, and this particular report was a relatively recent one, and it's quite a simple audit, looking at essentially safety of using an adapted model. And those of you who've done any oncology will know that children who get recurrent febrile neutropenia, or what do they miss? The parents miss having them at home, they miss time with their siblings, they miss time at school, and so on, and so on. It's all pretty tedious. And even if they're not very unwell, it's lost time somehow. So this idea was initially worked up collaboratively with the groups in the UK and Australia and Switzerland, and they developed an algorithm, really, a degree of risk by group, and came up with this so-called picnic data set. This Paediatrics, something to do with febrile neutropenia, I can't remember what that whole acronym stood for, with the intention of picking out those children who would be treated equally well, either in an ambulatory way or switch to oral treatment totally. So both psychological benefits potentially and cost effectiveness benefits too, for hospital time, beds, and so on. So this would be a good thing if it works, if it was possible to pick up these children, because there are a lot of them. If you look at the leukemics alone, that's a major burden on most general paediatric units. And in short, the children they deemed at low risk were the ones you'd expect. There were leukemias and lymphomas who were in remission, fair enough, just on a bit of maintenance treatment. So mercaptopurine, methotrexate probably. Low risk, so no infant leukemias, no bone marrow transplants, not on active immunosuppression, no fever focus, no additional medical needs. They didn't have oxygen requirements, fluid requirements, had normal parameters, didn't look septic. Parents were easy to contact and deemed reliable. I'm not sure how they judged that. And they didn't live far away. And this Australia, UK, Swiss group, the AUS group, was based on a score of 0 or 1 on these parameters. So one of the provisos was that the total white count was of 3, platelets above 50, some observation, and stable essentially. And without going into detail, I can say that they looked at these children who were discharged early on oral antibiotics, temperatures at home, and the parents are already well trained because they weren't new to the oncology system. And by definition, to get to maintenance, you've probably been in the system for at least 6 months. They were experienced. Daily telephone reviews, the discussion with the parents, and broad spectrum oral antibiotic cover, and then stopping early if blood cultures were negative. And so this particular audit just looked at safety and found that it was totally safe. There were no complications, no mortality, and I don't think they did any parental satisfaction assessment in this particular one. That would have been good to know. But essentially a win situation from what's a fairly common, fairly tedious for families situation. And even those that were culture positive were relatively well, and I don't think any required readmission. They continued the oral antibiotic combination. So, are any of you familiar with the developments in spinal muscular atrophy recently? Any of you working in genetics or neurology? Because this is big news, and in some ways, I'd say this is the biggest news of all of these. It's a completely new type of treatment. It's essentially genetic treatment or genetically enhancing treatment after literally decades of inertia in the neuromuscular world. I worked as some of you will know the name Victor Dubowitz, a neurologist in the UK. I was one of his juniors over 30 years ago in London. And he used to see a lot of children with both SMA and Duchenne's, and was always hopeful that something would change, and nothing really did. There was a suggestion that androgenic steroids might make a difference in Duchenne, and that glucocorticoids might make a difference, and they may have made a small difference, but ultimately a progressive disease, even with the nighttime ventilation, which was really the only thing that changed in the 90s, 2000s, even 2010s. And the same was true of spinal muscular atrophy. Really, if you have the bad type, this is pretty horrible. If you have a child with this, you have a child who's probably, or very likely, won't make it past his or her first birthday. And the phenotype's been recognised for many, many years now, over a century, I think. And but the means of treating it just have been tantalisingly out of reach until just a few years ago, when the genetic science came up with the idea that maybe something to do to augment the defective protein, the SNN1 protein, is the answer, but no one really knew how to do that. So the older methods of genetic treatment, which have been used, say, some time ago, cystic fibrosis, using adenoviral vectors, nebulized, just weren't applicable in this for SMA. But in short, let's go back a step and look at the pathology. So it's an autosomal recessive disease, which is pretty awful. About 1 in 11,000 or thereabouts. Doubt anyone knows the exact number, but it's characterised by progressive muscle atrophy and weakness, and 60% have the bad type, what used to be called Wernicke-Hoffman, and median life expectancy of under 2 years. Many died in the first year. largely from respiratory failure, and wouldn't reach motor milestones, obviously, and then just fade away. Aspiration pneumonia, very common final pathway. And then people started to look at replacing these absent proteins, SMN1 and SMN2. So nusinersen, which was one of the first two off the block. So it's an oligonucleotide which modifies pre-messenger RNA splicing of the SMN2 gene, which together enhance production of the SMN protein, which is the bit that's missing in children with this phenotype. And this thinking about 10 years ago led to some early trials, and this, as far as I know, the NEJM one was the first study we saw and has been extremely influential. So they randomized children to a single dose of nusinersen in children with SMA, and looked at motor response, essentially. They did a time to event analysis, looking at survival or time to ventilation, and followed them for about a year and used some standardized motor milestones. This published published 7 years ago, and since then, this has really things have really changed. Genuinely say things have really changed. So they found a substantial reduction in mortality. I can't remember what the hazard ratio was, but it was highly impressive. 0.5, and big difference in median time to death, and big difference in motor milestones. Not curative, of course, but gave the children a quality of life and their parents a quality of life that would have been unthinkable just a few years before. So this concept has really changed the way SMA is managed. And it's not just nusinersen. Since then, there's been several other studies looking at different ways of administration. The final common pathway has been enhancing production of SMN1 through genetic augmentation. So very recently that these genetic treatments have been available, but since then, on a seminar gene, which I think is what Salman has been using, has become very popular. There's even an oral SMN protein equivalent called risdiplam, which I haven't seen used myself, but I've seen the others used. And that's where things are. It's expensive, no way around that. But it, like all these things, if there's enough motivation and push, you can make it affordable for the families who need these sorts of therapies. But somehow, when you ask him for an update, I think treatment gave yesterday was at least the second one.
So the sixth one.
The sixth, okay. So he's very experienced with this now. And these children will live a longer and have a better quality of life, and that's no doubt about it.